Welcome everybody to the Random Anesthesia Topic podcast. In this episode, we have Dr. Natasha Bartel from King's Animal Hospital in Ontario. We have Dr. Ryan Bailey that works with us at Safe Pet Anesthesia. And I'm Dr. Gianluca Bini, CEO and co-founder of Safe Pet Anesthesia, a training and teleconsulting company. And I'm also an assistant professor of anesthesia and analgesia at Oklahoma State University. Let's get started. All right. I guess tonight it's my turn to ask the random question. So I think everybody's been talking about this. Do you have, there is a huge hype about, the new Premed, the GV20,
Bailey's reaction was priceless.
Ryan doesn't even count, right? Like he used to use his fucking Acepromazine. So
exactly.
There's nothing wrong with Acepromazine, Gianluca.
Thank you so much, Tasha. God.
It's a great sedative. It's underutilized in cats where it really smooths out the psycho for a few hours. Like
anti-emetic, long-lasting.
Just because something's from the end of the 20th century, like Bailey and I are, doesn't make it useless.
Exactly.
Let me get back to you on that. But no, jokes aside, right? So we know that there is different absorption at different spots for IM Premeds, right? So different muscle groups maybe have different absorption. Now, at the moment, there is this huge hype about the GV20 acupuncture site. What's your guys' take on that? I don't think anybody knows really how that works. Why does it have such a fast effect of action?
Well, it's on an acupuncture meridian, right? So it's in one of your meridians or your chi channels. In terms of the physiological effect, I mean, that area has low fat, low musculature, and is vascularized well. So that could explain the uptake. Yeah, but
do you use it?
No.
Yeah.
Why? The next question is why.
But okay, so is there evidence for it? Like, is there evidence that actually works faster or better?
I've seen it work like this. Now,
I'm not talking about anecdotal because anecdotal is crap and we know that.
Okay.
I mean, there is a paucity of literature.
I'd love to cite the papers from WCVA this year from Paris in which they showed there was really no difference. Shockingly, no difference. Like, my gosh, big surprise, everybody.
So is that published or is it an abstract?
They were abstracts. I think one of them might be. I'm actually in my reference finder right now to see if it did get published because I remember it was all. But I mean, it will be published, right? Because or no, I guess the producers don't publish the abstracts do.
Let's just go with Tasha's summary, which is, despite the WCVA, there's still a paucity of literature, even in a veterinary paper context, which means it's a double paucity from normal people. And there's still a lot of research and verification and even clinical outcomes to evaluate. And of course, don't forget the whole phenomenon of human-based confirmation bias, which is, I think it has faster uptake because I wanted to have faster uptake because it's the new and cool kid on the block. And so, I'm never the first person, like for the most part, I'm not the first person to do stuff. Like I like to sit back for a bit and see how things pan out. But I guess my point about this particular injection site is, does it, the core of it is, does it confer an advantage? And then in the face of this advantage is, what are the welfare implications to the patient? I mean, if I went to the dentist and you injected me square in the middle of my face, I don't know. I'm not sure. I mean, but like I said this in a conference recently where I was lecturing. I was like, I mean, I also get Botox, so I'm maybe not the right person to ask. But yeah, I really I don't know, like injecting something in the middle of its head over putting it into the tricep, the back musculature. What is so special about it that I'm missing out on? And
I think that's what people, I think that people are mistaking like faster for better, right?
True. Yeah.
Right. So like faster doesn't necessarily mean better,
True.
right? Also, like, sticking a needle in a, patient head may or may not be, you may not get bitten.
Brownie in her forehead with a needle. That's the last time you'll ever use that hand. So
So it depends on,
infection is also, I'm sure, part of it,
That's where I come from, is like, it's a lot easier to approach a patient who is like, in the patient population we're talking about, who's going to be these like great GV20 things, are probably not the most friendly patients, not patients you want to go near the biting ends, if you will. So I like biting ends as possible. And in a patient who's fractious, like maybe they decide to jump as you go for their GV20 and you get them in the eye. That's probably not going to work so great for everyone involved.
That's like the most grandpa statement. And then you get them in the eye. Like, you sound like you're in a Christmas story. Like, don't shit out your eye.
Like, like, I think it works just fine to, inject the epaxials or even the quadriceps, if they tolerate that or whatever.
Honestly, I have more concern about the back leg injection, which is supposed to be faster than the back, because 98% of the time I watch people do that injection and almost guaranteed they are coming millimeters within the sciatic.
I mean,
Every single time I watch this happen, I'm like, you're about to hit the sciatic, and then they just inject anyway. And I'm like, okay.
exactly. And it's like, am I struggling with epaxial sedation? Absolutely not. Not in my practice.
Right?
Like, works just fine. 90% of the time, it works every time.
Yeah, I like, for me, like, the back is a nice place because then you've got a really safe hold on restraint for the patient. It's a large area where you have to really make a concerted effort to goof that up and go somewhere where you shouldn't be. And I don't mind the back leg, but I go into the quadriceps. I don't go in through the hamstrings, which I see a lot of people do, because they're like, I keep hearing people be like, oh, I go through the back of the leg to avoid the sciatic. And I'm like, that's one of the actual approaches to the sciatic. So yeah, I have no issue with the back. And like I said, what does a shot into the face confer to me clinically or practically that, I should be changing practice? For me, it's too early in the situation to call. And
Yeah.
honestly, I don't have enough time on clinics anymore to be the person driving that like bulk of evidence. So
I also think to me, it's harmless as long as you can do it safely. I think it's just another way to go about it. But at the same time, my big concern is, so is GV20, like, okay, so first of all, I'm going to say, like, I am not anti-acupuncture. I think it has merits. I think it has a place. I think there's a way in which it works that we don't fully understand. That being said, I think this GV20 to me falls more into sub-Q sedation. And you know what? Sub-Q sedation fucking works. Like, you can do it. It's going to be a little more pain in your ass. Your absorption is going to be a bit more variable. Your onset's going to be a bit slower, but you can sedate things sub-Q just fine as long as you know what you're doing. So like, in some of the poster presentations, they sedated these cats. They use like 20 to 40 micrograms per kilo of dexmedetomidine. So like, they sure as shit got sedate, and sure as shit happened quickly.
Yeah.
why do I need it to happen within 2 minutes anyway? Like, why do I want things to drop right over? Like,
Right. Well,
I don't,
so that actually is like a good point from us, the anesthesiologists, who are like, our day
I don't like it when things just fall off needles as a general rule. It really relaxes my internal sphincters when you inject something just keels over. Like, I don't love that.
I think in busier practices, though, some people feel as if they don't have the time. Like, they're now so focused becomes this patient, and until it's sedated and anesthetized, they can't work with it. And so that creates like this.
They're
I'm
just
not saying, I'm not
Bailey. They're just bad at time management, not sedation.
Well, yes, I agree, but they view it as like, well, this dog won't get sedated, or this cat is recalcitrant.
Is that what they shout out in their fit of rage, is recalcitrant? I doubt that. You would.
I mean, I would for sure.
You weird old grandpa, you would be like, we're going to get shot in the eye if this is recalcitrant. Oh. But yeah,
Just another little random anecdote. One time, just speaking of IM injections, Carolyn had to get a vaccine for tetanus, I believe, because our cat bit her hellishly in the hand
because Lucy is a psycho.
Lucy is a psycho, straight up. And so she had a vaccine for tetanus because she hadn't had it in a while because she's an adult. And they were like, where do you want it? And she was like, what do you mean? And he was like, well, you could have it in your arm or like your thigh. And she's like, I don't know, maybe the thigh? Like, why? And he's like, yeah, some people think it hurts less. And like before Carolyn could really even like pull up her pant leg or whatever she was wearing, the guy fucking like blasted her in the thigh. And she was like, oh, okay, that was fine. No big deal. So like, again, thinking about these big muscle groups like the apaxials, like dogs get bit by, teeth that are much bigger than our stupid little tiny needles.
I mean, I will tell side anecdote as a kid, like this is the early 80s, just to qualify. So, the late 1900s, as it were. And we received like a routine childhood vaccination. I'd have to ask my parents which one it was, but I remember that at that point they had switched the protocol from the upper arm to the thigh, like, because it was a school-based vaccination. All you anti-vaxxers, calm down. This is Canada. But anyway, and we ended up with a neuritis, despite the fact they went in the quadriceps. And I remember being like incapacitated for at least a week, if not longer. And my sister was as well. And it happened in numerous children. It was like this whole adverse injection site vaccine. Like I said, I would have to go and ask my parents which one it was, but it was like, like I remember in the first couple of days, like my mom would be on the sofa in bed and like she'd carry me to the bathroom and because I just couldn't use that leg at all.
And that's how you become an anti-vaxxer.
Listen, after the reaction I had to Moderna, that almost killed me. I'm
surprised you're still not an anti-vaxxer.
Moderna almost killed me. I'm sorry, Moderna. I did report it as an official adverse event, but I still get vaccinated with my regular routine for veterinarian for rabies and tetanus, and I travel everywhere, so I get vaccinated for thrilling things like cholera and typhoid because I don't die like a Somerset Maugham novel. Anyway, so the point is yeah, I this GV20 situation, and just to be clear, I'm a big proponent of Eastern-based medicine. I mean, they got 3,000 years of practice on our 150, and I also practice Tai Chi, so I'm familiar with like the Chi flowing through my meridians and things like that. But I also understand human-based psychology from the point of view of placebo. And I also don't understand, and I don't know if this is anesthesiology or does this happen to the other specialties, but like, just like it's like Elvis Presley crazy over anything new that ever happens. And I'm like, is our baseline of boredom so strong that like the tiniest like winds of change make everyone go completely mental and lose total perspective? But I'm always like, one little thing comes out and all of a sudden that's the only thing we can talk about at conferences, and it's everyone is doing it, and oh my God, it's so much better. And I'm always like, nothing has happened. Like subcutaneous ketamine is another example, right? Like, now
I'm still waiting for the evidence.
Where is it?
Yeah, and now I'm watching as like all these stuff coming out about like things are being over gabapentin and how they're actually improving things like their mobility and their day-to-day mentation after you actually put them in gabapentin withdrawal. And it's just like people are just so, I don't know, impatient, or they get so impetuous. I don't know what it is. I'm not a psychologist, obviously, but there's something in veterinary anesthesia where like one little thing happens and everyone just goes bananas about it. And you're just like, when did the rigorous process of scientific validation get tossed out the window? I don't know.
I mean, at the same time, though, like it has to come from somewhere, right? Like we have to start, like we have to continue to try new things, advance the science, advance the medicine, et cetera, et cetera. But I think there are always going to be early adopters. There's going to be someone, and this maybe GV20 is going to be right, and maybe we're going to all change our tunes in 5 years when the evidence comes out, and like papers, theoretically with open access should be coming out sooner or whatever. I'm not like, I'll be honest, I'm not the most smart about all that journal stuff. I'm not going to lie, but like theoretically papers should be, coming out reasonably quickly, or at least being able like accessible online with kind of like print subscriptions being not as big a deal. But like, until there's the evidence, I'm hard pressed to make big adjustments. I think with some of the nerve block stuff is a great example. Just because you did it on a cadaver and prove that it worked on the cadaver, you don't know that it's safe for the patient. And like it takes like the theoretical nerve block concept in, you know, taking from the human side, adapting it to the dog, and then putting it in a live model there's a whole process to go through. And like GV20 theoretically could speed run the process because we know, you know, it's essentially a sub-Q injection with like a little bit of a twist, if you will.
Yeah.
Like I'd love to see the evidence. I am willing to change my practice. I have changed my practice since I started residency to finishing residency to like I've been out of residency, I don't know, 8-9 years almost. And like I've changed my practice in multiple different ways based on evidence, based on things I read, based on conversations I have, and then going back and reading what people did.
I mean, and like, you know, you're not wrong, Bailey. You know, someone does have to push the envelope and maybe, you know, ruffle some feathers. And you know, that's not necessarily me clinically, but, you know, I'm happy that those people do it. And I also, you know, I always say like it's so hard in veterinary medicine where you get like 1 or 2 papers and it's like there's 6 cats in the study and the 6 cats are healthy.
Hey, now they are doing power analyses in most of the papers that I read nowadays. Like we have come a long way from 6 research cats.
No, we haven't. And no, we haven't. And you get these, you know, like 12 healthy beagles from the research population. And then, you know, like we tested pantoprazole versus famotidine and then while they were awake. And then all of a sudden we make large extrapolations about efficacy in sick anesthetized patients. And so
that's where the
how I feel about the veterinary literature as a body. And like, you know, it's tricky because on the one hand, you want the evidence, but on the other hand, the quality of the evidence and the bulk of the evidence is important too. And we just don't generate the data that human medicine does. But I also say too, you know, like we joke that, you know, clinical evidence is like the bottom of the pile. Like it's the 6th lowest form of evidence that you should use when making clinical decisions. Okay, fine. But I always struggle with the fact that it's like, you know, I've done this 21,000 times and this paper in 4 healthy cats is telling me that I'm wrong, right? Like I worry a little bit that sometimes we dispel the art of experience and the art of practice. But then again, like how do you ratify that? How do you objectify that? And I understand that. So the other thing too is that there's no way that a series of like, you know, 3 clinical trials or 3 clinical trials can give you the same kinds of outcomes and data that, for example, something that's gone to market gives you after 40 years.
Right.
Right. So, you know, everything does have its place and fits together in the whole picture. But like right now for GV20, it's so early on the teeny weeny spectrum of relevance that, you know, am I going to go in tomorrow and inject everything in its face? No. Right. Am I open-minded that it may become like the preferred route?
To my mind, like if we have the right patient, you know, where I think it's something to try, sure. Why not? Why not see if it works? Like
it seems to do well in like, you know, those happy-go-lucky like dum-dum dogs, you know, like a golden retriever who's just like just thinking about like peanut butter and doesn't really care and you can just like pop the needle right in their forehead. But like I'm very recalcitrant about how that's going to go in a cat. Especially a fractious cat, especially a fractious cat that requires 5 people to like hold it down, like a, you know, pot roast that has been lit on fire.
Think about putting an e-collar on that. Like, how many times have you seen the e-collar's coming in and they just fucking nail it with their teeth? And it is like, now you have the cat and the e-collar's cutting its up and it can't close its mouth. It's like, ah! And you're like, oh my God, this is my definition.
For whoever is listening, please go. You can watch this in the interpretation of the cat stuck with a collar on either YouTube or Apple Podcasts.
That should definitely be the promo clip.
Yes.
For anyone who doesn't watch, you really should, because I have decked out the whole office. We now have the Bears hat here. We've got the Bears hat here.
Is the Bears
shirt.
Is it the baseball team of Chicago?
Oh,
it is
God,
the football team. They're in the playoffs. They just beat the Packers in a thrilling game.
The Bears. It's an American football team, not a soccer
mustache.
team.
Talk about things in the 1980s.
I only care about NBA, so sorry.
If Bailey gained about 250 pounds, he would be straight out a guy from like the Ditka skits of like the 90s SNL. Like
Ugh,
the plaid shirt, he's got the hat, he's got the stash, he eats hot
my
dogs.
fucking
Nice.
heroes. I had hot
Nice.
dogs this weekend, in fact.
We know. We follow you on Instagram and we see you post about hot dogs.
They were good as
Yeah,
hell.
everybody knows, right?
I'm a good friend, so I like it, even though I'm like, I don't know what the fuck he's eating, but he is gonna die.
Yesterday, actually, I was at the OKC Thunders game, and I got this like they have this hot dog flight, so it's like they call it like the Big Three.
Hell yeah.
The company was like Schwab, I think.
Sure.
Schwab
Like
meat,
Schwab Investments.
I don't know, whatever.
I
But
had hot dogs now. Everyone's getting into hot dogs, all right?
Look, Bailey's
one was-
he's never heard of Schwab hot dogs, and he thinks he's like the god of hot dog
I
knowledge.
don't need to hear about these fucking non-Chicago-based hot dog brands because they're all shit. Chicago's the only place that makes
okay,
hot
okay,
dog.
Ryan. So I had this hot dog.
Dang, that sounds good. I'd eat it.
It was really fucking good. And then there was one with a chili dog, and then there was like a classic one. I never had the brisket one. It was really fucking. I had the chili before,
Yeah,
but
great.
the brisket one was really fucking good.
Sure.
The classic was okay, like it was good, but nothing special. But the brisket was legit,
Yeah.
really good.
It's just like I Am Sedation. It's the classic for a reason. Briskets.
I was so waiting for somebody to tie in hot dogs with I Am Sedation there, and I was just like, and boom, there it is. Because I was like, yeah, sounds like the brisket hot dog is like the GV20 of hot dogs, but like
It's a positive thing, but it's got no staying power.
that's right.
Nice,
Right.
nice.
Not like the classic Chicago hot dog that we're still fucking eating like almost 100 years later.
Nice. I love that. Jesus.
Do you think so that
G20 for this whole podcast, or are you moving on to another hot
we're
topic?
moving on. If we
one more thought. Are we misinterpreting GV20 as being successful? Or are we just relearning about subcutaneous administration of drugs? Like that's been my big one. Like, are we just relearning that sub-Q is a route you can go? I personally don't love sub-Q.
I think the question is are you, obviously there's a component of subcutaneous, but because you're putting it on a chi meridian, is it actually causing some sort of different flow in the energy of sky and earth, which can be very, esoteric, but at the same time, that's the real question. Like, is this a magic?
Acupuncture does work. Like, I think,
yeah.
I think it does work. The question is, does it work because of the acupuncture point, or does it work because of, the vascularization? And if they claim that it's faster is real, right? Which that paper at the World Congress seems to disprove. But let's say it's real, then is it because of the vascularization, or is it because of the acupuncture point? Nobody knows. So if you were to premed an animal IM, what's your spot? Do you have a preferred muscle group?
Apaxials.
Me too.
All the time.
Me too, because I see so much like.
Do you ever use the neck?
Oh.
Like if I do.
Interesting.
Or horses.
I mean, yeah, pigs usually it's behind the ear, right? Because it's the
Pigs
less.
versus cows. Like as a dog and a cat. No, I think the cat's too small and vicious.
I've done a bunch of.
I want near the end.
Yeah, during my residency, I've done a bunch of dogs with like premed in the neck. There were some papers where, the dorsal part of the neck, of course, like not the.
Yeah.
But the.
Heel part.
I mean, just put a disclaimer in there, right?
As a humdinger.
There was some studies done in England, I think, where they looked at different muscle groups and uptake from the different muscles. And it sounded like the fastest were the intercostal, which usually you don't really want to inject there, probably.
YOLO.
Whoever injects in the intercostal, I'm gonna hold you down and inject you in the intercostal. How much you fucking like it. Let's just put like a side note here that intramuscular injection is actually not that comfortable, right? Like it can be quite ouchy. And when you do it in a place that has like confined boundaries or is like a high degree of sensitivity, like God, I mean, when I used to play rugby, the worst thing was is like if you bruised your ribs and like your intercostals, like that's just the worst injury. I was like, I'd rather break a finger or a toe or have a concussion. I swear to God, than do that.
Well, long term, you don't want to have.
But the second fastest muscle was the neck,
Oh.
and then there was, I think, semi membranosus, and then there was the epoxyls in the end. I think, I don't know if
the one I actually use a lot, and you'd be surprised, like more than I think the average bear, is the triceps. Especially because a lot of times, like if we're doing hind limb procedures and I need to top up something, like let's say I'm going to do IM diphenhydramine.
Oh yeah.
Or something that's having a reaction. I actually give them the triceps because the triceps has a nice bulk of muscle before you get to that like that radial nerve, right? And in most animals they don't have tricep wasting. Like you will see, for example, in like a TPLO who's been chronic and they, like their hind limb musculature is really poor. So I do use the triceps a lot. That one, and like it's a good one to get to if you're kind of having a little bit of a struggle with the pet as well. And I, whereas Ryan stays out from the biting end, I like to stay away from the poopy end. So
that's what gloves are for.
Well, that's why I went into anesthesia because I'm not interested in bodily fluids.
Oh my God, yeah, not at all.
I can really walk through dermatology because I'm like, oh.
I know we're talking more about sedation here, but for IM, like the radial is a great. You almost always have access to it in the anesthetized surgical patient, or even like not the dentistry patient, but like you have access to that muscle group in a lot of the cases you're going to be running. And so it is a really nice, accessible spot. So you don't have to like first of all, you don't want to get out of your chair if you don't have to. You can access the patient. You can go back to sitting down. You don't have to like go finagle under the drapes and move whatever surgical instruments they're going to touch next.
Typical anesthesiologist, right? Doesn't want to get up from his chair.
I mean, who does?
Must be nice now that you work remote.
That's true. I don't ever get out of the chair.
You don't have to even like move your ass from the chair. You need a coffee machine right next to your laptop, so you don't even have to get up. You can just do everything.
The dream. I'm more like a cold brew right in the morning. Just get all that caffeine right away, and then pretty much done for the day.
Why would you do cold brew?
I find that hot coffee tastes acrid. It tastes too bitter. I love espresso. Espresso, fine. Like I'll drink straight espresso shots. Like I have no problem with that. But like hot coffee, like it'll be this weekend. It's gonna be super cold. They're reporting. I'll be drinking cold coffee.
Oh wow! So do you ever go to Starbucks though?
I hate Starbucks.
You hate Starbucks?
We're not getting. Hey, Starbucks, listen up. We don't want your sponsorship. All right. Okay. I think all their coffee tastes burnt.
I mean, you rarely go to Starbucks because the coffee is good, right?
Yeah, the only time is like if we're in an airport and we're like desperate, and even then I'll be like, I don't know, I think I can survive. Do
you go to Starbucks, Tash, or do you go to like Tim Hortons or some shit like that?
Well, Beanie, at every opportunity, I will intentionally select Canadian over American when possible.
Look at you.
But I'm also not a big coffee person. I'm a tea person, which means that matcha? Matcha, you can matcha and yerba are like no. I'm a tea person, and it's hard to justify spending $7.50 on a tea when I can buy a box of 100 tea bags for $3.99. So, if there's like an order going in from like the anesthesia group and I'm on clinics that day, yeah, I'll toss like a chai on or something. But for the most part, nah.
Okay. Do you like matcha, Ryan?
I cannot say I have had matcha. I love tea of all varieties. I will say the quarterback, Caleb Williams, he loves matcha, and the Bears do super well when he's seen drinking matcha with his wired headphones. So, I swear to God, matcha had a moment in Chicago this summer. Every farmer's market where there was a matcha stand, it was like you like, oh, look at that line wrapping around the block. I bet that's a matcha stand. And then you walk by to go buy your product, and it's fucking matcha.
Are there matcha hot dogs?
I'm sure there are.
Disgusting.
There are.
Just like GV20, you're either really into it or you're not.
Yeah, like
I
hot
love
dogs.
matcha.
Do
Really?
you?
Yeah.
What's it taste like?
Grass.
Like, yeah, there's a little bit grassy.
Like green
So there
tea.
is this place here in OKC, which actually, so there is a huge Asian community, which I love. And there is this place that does like this drink where it's like the bottom, it's like ube,
Oh, cool.
and the top is matcha.
So you get the good flavor from the ube and then the grassy flavor from the matcha.
Correct.
Yeah.
Correct. Which is actually really, really good. There is a couple of spots in New York that make amazing matcha. One is called like Haiti, and it's so like they hand whisk it in front of you, like it's like
Yeah.
it's legit, really good. It's expensive, but
I mean, green tea and yerba mate were my like gateway drug to caffeine. I used to drink yerba mate all the time.
oh yeah,
when I was at
I
vet
love
school.
yerba
That's why I
mate.
like got through vet.
The bottom of an ashtray has been rinsed out.
I mean, the ones I had tasted very grassy, and I
The
did not.
ones that I had were made by true Argentinians
Sure.
because I trained in Cornell, and everybody there is from South America.
I did
And
not
I
have
was
the
like,
fancy yerba mate cup.
yeah, that, of course. And they would be like, here, let's drink some yerba mate while we study the physics of gases. And I'd be like, you know, what's worse than the physics of gases? This yerba mate.
No.
So,
Gas physics.
You're so bad. Fucking worst.
yeah, I'm becoming a real curmudgeon.
Becoming?
Oh my god, Tasha.
Huh.
All right. So moving from, master groups to, do you, so, what?
Nothing. It was just like you got like deeply philosophical, like you leaned back and you looked
Where are
at
we going?
Like,
Evans, and Bailey and I are like, what is he ask?
no, nothing too deep. But so I'm trying to think, like, so a lot of places, the way we were trained, I mean, all of us actually have been trained in a vet school, right? Like residency wise. So usually the typical pre-med, it's IM, right? Or rarely we did pre-med IV in a vet school. Do you think there is any disadvantage in like IV pre-med versus IM pre-med,
Yes.
such as?
I didn't know if anyone else wanted to chime in and be a counterpoint, but yes, I think there are advantages and disadvantages to both. I think from a clinical standpoint, I see a lot of people pre-med and then go straight to induction, and it drives me bonkers. I think I'm talking about IV. So we give the IV pre-med, and then we like put the dog in the mask, and then we get our induction drugs, and I'm like, that patient's not sedate, induction's gonna go for shit, good luck. Or we give the IV pre-med, and then we've had a bad experience, a patient's arrested, whatever, like we've had some sort of bad event in our life because the IV pre-med hits hard and it hits fast, and we left that patient unattended and something bad happened. So now we do things like we give the IV pre-med, and then we sit in the busy induction suite with everything moving around, and the dog is in the middle of everything, and there's all this movement, and the dog does not become sedate because it's a very stimulating environment, and it overrides the sedation. And then once again, induction goes to shit. I think they are equal. Like, I think they each have their place.
And it's situational, right? So like depending
exactly.
on
I would not say like, oh, I'm never gonna IV pre-med an animal, or like only IM pre-meds, or whatever. Like, I think all of it has its place.
Right.
I think we just like, I love IV pre-meds because I can also get away with a lot lower doses though. And that's great too. So like I can use a lot less dexmedetomidine. I can use maybe lower doses of opioids potentially.
Yeah. I think it depends on you.
Yeah, and it opens up an arsenal to some drugs that maybe you wouldn't give IM or whatever. Like, no, the propofol or Faxone really count. Those are more induction, but like lidocaine can be given IV as a sedative because it does, at higher doses, cause a degree of sedation.
Yeah, you sound like somebody from the OVC.
Beanie, what about you?
But so I think that, as Ryan was saying, I think that it has its place, right? So it depends, I think, a little bit also on what drug you're giving as an IV pre-med, right? So
Right.
if you are planning on giving opioid only, maybe the sedation you're going to get is probably none. I don't think that the purpose of giving the opioid only then. So what Ryan is talking about is the fact that if the patient does not get sedated, you do not get a good sparing effect on your induction agent
Yes.
or your induction combination if you have more than one, right? So if your plan is to just give an opioid in pre-med, whether you give it IM or IV, I think that probably doesn't fucking matter, right? Because the sparing effect you're gonna get from zero point 0.2 or zero point 0.3 mg per kg of methadone, or it's probably almost none, right? Regardless of how the fuck you want to give it. Once you start playing with like Acepromazine, if you give it IM and you give it time, probably you do get sedation. If you give it IV and 5 minutes after you induce, yeah, good luck getting any sedation from that, right?
Yeah.
If you are planning on Dexmed, different story, right? Dexmed IV, it's actually relatively fast. And so, like, I think that the drugs you're choosing play a big role as well, not just the setting, right? So I think so. I'm very much of a Dexmed guy. So if I need to premed IV, I'm heavily relying on an opioid and a Dexmed, even 1 mic per kg, and that 5 minutes after you can totally induce 100%. If I was more of an Acepromazine guy, probably that's not gonna work. If I pre-med and then 5 minutes after induce, I'm not gonna get what I want, or not as much as I want, I think, right? Yeah. What about you, Tasha? What do you?
I mean, I think you guys make a lot of good
Judging.
points. What?
You're just like sitting back, like silently judging both of
Yeah,
us.
she's judging both of us 100%.
Like, have we met? Yeah, like I think you guys make some good points. This is probably apparently unlike mechanical ventilation, not the hill I want to die on, but would rather give IV 99% of the time. And I like the IV because,
Interesting.
yeah, like, ooh, mic drop. I like IV
Lean
because
in.
it's more predictable, fast. We can use lower doses.
Totally true.
And also, it doesn't hurt. Like, I am very needle adverse.
Yeah, but you had to shove a catheter in without
Ding, ding.
pre-med,
And
which
that
does fucking hurt.
Yeah, that feels way weirder.
What
Huh?
hurts?
Catheter.
Yeah, the catheter hurts for sure. But
Isn't
so,
it the same as the fucking needle?
well, if you have to put a catheter in and give an IM injection, or you just put a catheter in, what's your net total of discomfort? It's higher with the IM injection.
Well, okay.
Which I've been
You're making
burned
some
for.
assumptions that I think are not true in clinical practice, unfortunately.
Well, they are in clinical practice because I can get an IV in almost anything before I have to sedate it. But I mean, also too, I've also been burned, and this is a little more academic, but given a Paxil injection and then send something to MRI, and then if that is anywhere crossover on where the lesion may potentially be, you look like a massive dodo. But like I said, I don't enjoy intramuscular injections myself. I think they're uncomfortable, and I think they leave you being sore. And then I also feel really terrible for those dogs who, like they get poked like multiple times. I mean, just think about when they do the heartworm treatments.
Oh, fuck.
Those injections, like those injections hurt so much to hospitalize them and put them on narcotics. So I just, I also come from a clinical point of view where, at my clinical peak, I was doing 20 to 30 cases a day as the only anesthesiologist with my team, right? And so I am, and I'm great at time management, but I am.
Are you saying that you're not at your peak anymore?
No.
You're in line.
Yes, I'm in the slide towards annihilation and death. Leave me alone. And yeah, AKA I don't give a fuck at 46 anymore. But yeah, I just don't have time for patients to take 30 to 40 minutes to sedate and then potentially sedate poorly. And the other thing too is I actually think that you do have to really monitor those sedated patients, and that's when they're getting really hypothermic. That's another disadvantage of IMing them and dropping them and ignoring them is they get really cold. So yeah, I actually go for the catheter and then the IV, although I understand the timing of my medications and how long they take. Like I don't just like slam fentanyl in and then give propofol. In most instances, I can think of a couple where I actually probably would do that. Yeah, I was like, I might actually do that a couple times. But yeah, like for the most, like something straightforward. Like if I can get your catheter and give it to you IV, I feel like I have a better sense of what I anticipate the outcome to be. I'm moving more efficiently. I think it's more comfortable and less distressing for the patient. And I just think, there's less fuck ups, right? Like how many times in IM of like the patient jumps and you bend the needle and I don't know how much it got. And then like, or how much went on, how much did I just, ketamine did I just squirt in my own arm? And like, did it go in fat or did it go in muscle? Like it's just messier and I don't like it.
I
But
just
like
want
it's
to bring up a couple counterpoints here.
It's not the hill I'm gonna die on.
So you are proficient in your catheterization. You're a one stick queen. One stick every time. But you are incompetent with IM injection and routinely spray drug everywhere, break the needle, get it in your eye. So somehow the dexterity of catheter placement is in your wheelhouse, but IM injection, not for you.
I don't mean personally, Bailey.
Oh, okay.
I think that, when I watch different sets of teams do IM injections, and you're right, you might jump to from a catheter placement type thing. But in those where I anticipate, like, if that patient is going to be fractures for the catheter, then I do err on the side of the IM injection. But like I said, my preference is if I can place the catheter and give your premed or your premed sedative IV, then that's my clinical preference.
Sure.
Okay.
I think one reason I push back on the IV premed over everything else, and it's not a hill I'm going to die on, but I do feel a little strongly, is people are really confident in how fast they are. And I'm like, I bet you're not as fast as a fucking IM premed, man. I bet I can give this IM premed while you're goofusing around, doing whatever you're doing, running blood work, getting this and that together. And by the time everything's done, the patient will be cooked and I'll be ready to go off to the races instead of like waiting for you to get the catheter and then pull the blood and then give, like, to me, there's lag time in even some of those add-on emergency cases that are coming in where I can hit it with the IM premed, go about, be setting up, doing all this other stuff while someone else is holding the patient and doing the monitoring for me, if you will. And then by the time they get the catheter in, that dog's ready for me and I'm ready to go.
Fair. Yeah, I don't know. You both have good points on this. Yeah.
Yeah, like I said, it's not a hill I'm going to die on because I think at some point it just comes down
There's preference.
and also what kind of clinical scenarios you need to run or your team's skill level. I don't know. I think it's multifactorial, but yeah. I don't like IM injections personally, so I try to avoid giving them. That's all. That's really the crux of my practice. It's like I think it's uncomfortable, and anything I can do to mitigate that is I try to err on that side.
Yeah.
I mean, I get yearly IM injections and I survive them every time.
I know you're surviving them, Bailey, because you're here to annoy me continuously.
I don't like the needle, though. No, it's the needle. I'm like, oh, that needle scares me. I can't look at it.
If I didn't have to get another IM vaccination to go to some weird tropical buggy country that I can't stop going to, then I'd be okay with that.
Sure.
Yeah.
You guys, that's awesome. And last question, then I'm gonna close on this. Do you always change? So you withdraw from the bottle, right? Whatever drug it is. Do you always change your needle
Always.
to give the IM injection?
100%.
There's a really cool
At least we can agree on that.
literature here. There's that cool paper that shows the needles, like all the fucking little heads on that.
Oh yeah. Yeah, it's pretty bad.
They change the needle when they give you a vaccine. They drop the needle.
They do, but some people don't, right? Like, so
oh yeah.
Sort of doing like a para-incisional line block for something or like a ring block or something, like one of the cruder, less specific blocks.
Yeah.
I change my needle like constantly throughout the block. And I'll tell you this too. So I get, a personal health disclosure, but I got 37 Botox shots to my skull and the base of my skull, my neck, my shoulders, and my forehead for chronic migraine syndrome, right?
In
And what
one
is
shot.
you get it's like multiple needles. I get like, but each needle has 5 injections in it, right? So I get all these whatever, but they don't change the needle on that syringe, even though it's 5 to 7 injections per that syringe. And let me tell you, I will tell you this, by the 5th and 6th and the 7th poke with that same needle, even though it's like a 27 gauger and it's only going into, it's going to my, like they literally,
maybe they just see one injection right in your GV20 and then you'll be just
they
fine.
whale me right like here in one of your chakras, and then like up here at the base of my skull. Those are 2 of my main injection points. Hurts like stink, but let me tell you, by the time you're past like the 2nd and the 3rd poke, I can feel the needle getting blunter because it hurts more and more progressively as we inject. And like Bailey said, like you can look at those electron microscopy photos of how blunt the needle is per usage. So like I said, I do not enjoy needle discomfort. I'm needle adverse as a patient. So I change my needle like the dickens.
Yeah,
You
that's
can,
fair.
I mean, another good example for anyone who's like out there practicing clinically is like when you're using a 24 gauge catheter, notice how dull that thing gets within like the first 2 or 3 pokes. Like, even like,
I don't like even if you don't like the catheter doesn't seed blood and you don't
right,
clot it or whatever, like
I don't reuse it
I
ever.
change my catheter per poke. I don't even poke with it twice
yeah.
because I think catheter pokes also hurt.
Oh, I
Um,
totally
yeah,
agree.
like when you put it in the back of your hand, you're like, uh, uh, but like I said, going through thick skin and like you sometimes hit the
Yep.
bone or the muscle or what have you, especially if you're new to the skill, and it's just like, and it's not as sterile as it should be ever. Like that's very rare. So I don't poke multiple times with that catheter.
Yeah.
That's a one poke situation for me.
But those are good examples where you'll notice that dullness come in just so fast. Like those catheters, like you can feel it in your fingers of like
Yeah.
how like it all of a sudden it's like you're pushing a catheter through fucking concrete and you're like, well, there's no chance at that point. Like just get a new catheter. So like
Yeah.
I think it's worse in the smaller gauges because I think they're less sturdy. Like
Honestly, I feel like I can feel it too. Like, let's say you're putting the same needle into like, and you're poking it multiple times into like whatever, like maybe a multi-use vial or like a bag of saline that you're drawing from or something. You can feel each time too, like the poke is harder, the poke is harder, right? And like you think about something like a geriatric cat who's got that like delicate chickeny paper skin. How much does that have to hurt if you whale them like 5 times with the same needle? Like, it's just friendly. And I also think it's making whatever technique or skill you're trying to achieve more difficult. And it's one of those things too, like needles are not cost preclusive in most instances. So it's like, why am I this 2.1 cents that I'm saving the hospital today is probably not going to make a difference in like,
Absolutely not.
yeah.
Yeah. Agreed. All right. Well, thank you so much for being here tonight. I guess see you next time.
Thanks guys.
Bye. Go
Thanks.
Bears.
Don't be a waste of a pump.